Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I will be discussing a very important topic in the cardiology, that is the heart failure. So in this session, I will be discussing the basic pathophysiology and as well as like the definitions and how to diagnose the heart failure. So mainly I will try to concentrate on the pathophysiology, and in the subsequent sessions we will be discussing the clinical features, the signs and as well as the diagnosis as well. So what are the most common etiologies that will be causing the heart failure? Very important etiologies are the hypertension, coronary artery diseases and then the valvular heart diseases. So previously, before this terminology, the heart failure, what we used to use this term as the congestive heart failure, because there is congestion of the lungs and there is systemic venous congestion as well. But in the later times, what has been found is not all the patients of the heart failure are having the congestion. So rather than using this terminology congestive heart failure, these days only the term heart failure is being used. And what will be the very important clinical presentation in cases of these heart failure and what makes the individual to bring or come to the hospital? So if it is secondary to the left heart failure, the patients usually present with dyspnea and as well as excessive fatigability. And if the etiology of the heart failure is like right heart failure, then the individual will present with the edema, that is peripheral edema or the pedal edema. That will be the usual clinical presentation in cases of the right and as well as the left heart failure. And how is this heart failure being classified? The recent classification of the heart failure is based on the ejection fraction, right? So if you take the normal ejection fraction or near normal ejection fraction as more than 50%, so the heart failure is classified as the heart failure with reduced ejection fraction, where ejection fraction is less than 40%, and the heart failure with preserved ejection fraction, where the ejection fraction is more than or equal to 50%. So this is how the heart failure is being classified, that is based on the ejection fraction of the individual. And in this session, I will be also discussing about the compensatory mechanisms which are activated and what are the various pathophysiological processes that occur in the heart failure. So if you take the overview of the topic, I will give you the various basic definitions like American Heart Association, what is it defined as, the European Society Association, what is it defined as, what exactly is the heart failure, what are the phenotypes and as well as the causes of heart failure. And we have a terminology called heart failure with recovered ejection fraction. What exactly is that I will be discussing. Then heart failure with mildly reduced ejection fraction. What is that I will be discussing. Then finally the various pathophysiology and pathophysiological changes that occurs in heart failure. All that we will be discussing in this session, right? Now, so if you see this, the clinical definitions of the heart failure, as I have said you just now, that heart failure is a common final pathway for most chronic cardiovascular diseases, right? That is a final common pathway for an individual with untreated hypertension, for an individual with coronary artery disease, and for an individual with valvular heart diseases. So these are the for all these scenarios, the clinical scenarios, the final common pathway, if not being treated, they'll end up in what is called as the heart failure. Now, according to the American Heart Association and according to European Heart Association, how is or what is this cardiac failure defined as? Let me explain to you. So, according to American Heart Association, the heart failure, it is defined as a complex clinical syndrome that results from the functional and as well as the structural abnormalities of the heart. Okay, so it is the structural, right? What will be the structural, like in the form of valvular heart diseases or coronary artery diseases or cardiomyopathies, or the functional abnormalities of the heart. What will be that functional abnormality? Either it is systolic dysfunction or the diastolic dysfunction. Okay, so because of this structural and as well as the functional abnormality of the heart, there is impairment of the ventricular filling, right? That is decreased ventricular filling, or there will be reduced ejection of the blood. right, there will be reduced ejection of the blood from the heart. And what will be the usual presentation of these individuals? That will be in the form of the dyspnea, fatigue, that is because of decrease in the cardiac output in the individual, and then the fluid retention. So this is what according to the American Heart Association. Then you take the European Heart Association or European Society of Cardiology. So European Society of Cardiology, it defined or it has given the emphasis on the typical symptoms, like what it said the typical symptoms are breathlessness, ankle edema, and as well as fatigue. And it also described the signs in heart failure like elevated jugular venous pressure, pulmonary crackles, and the peripheral edema. Okay, so these particular signs and as well as the symptoms, they are caused by structural or functional cardiac abnormalities that results in decrease in cardiac output and as well as elevated intracardiac pressure, right, elevated intracardiac pressure. So either these manifestations can occur either in the rest or during the stress. So this is according to the European Society of the Cardiology, right. So as I have said you previously also, that what is the difference between only just heart failure and the term the congestive heart failure. So previously we used to use this terminology called congestive heart failure, but all patients, right, all patients with heart failure, they don't have this signs of congestion, and that is the reason why, right, that is the reason why only terminology heart failure is being preferred rather than the congestive heart failure. And in this congestive heart failure you have these two things. It includes both right heart failure and as well as the left heart failure as well. And what exactly is the definition of the heart failure? See, this was, so previous things what I have said was like according to American Heart Association and according to European Society of Cardiology. But in the pathophysiological terms, the heart failure, it has been defined as the syndrome, or it has been defined as the features which are characterized by elevated cardiac filling pressures, right, elevated right heart filling pressures, elevated left heart filling pressures, and there will be decrease in the cardiac output. So because of elevated cardiac filling pressures in the left ventricle, there will be decrease in the cardiac output. And because of decrease in the cardiac output, there will be inadequate peripheral oxygen delivery at rest or during the stress. And this particular decrease in cardiac output, it is caused by the cardiac dysfunction, right? It is caused by the cardiac dysfunction. So that is the definition of the heart failure. So in the pathophysiological terms, the heart failure has been defined as a syndrome characterized by elevated cardiac filling pressures, and there is inadequate peripheral oxygen delivery at rest or during stress caused by the cardiac dysfunction. So that is a basic definition of the heart failure. Now this particular heart failure, these patients, they present either in the form of an acute heart failure or they present in the form of the chronic heart failure. So you take this chronic heart failure. Chronic heart failure describes the patients with long-standing signs and symptoms, right, long-standing signs and symptoms. So if you see this long-standing signs and symptoms, they include, I mean, these features, right, these features, they are present in the patient since many years, right, they are present since months to years. And how are they being treated by? They are being treated by either medical management or the device therapy. Okay, so that will be, right, so that will be the treatment for the chronic heart failure, where the individual will have the clinical manifestations for months to years. Whereas you take in clinical scenario of acute heart failure. This acute heart failure, previously it has been termed as acute decompensated heart failure. This refers to rapid onset of the symptoms, right? Rapid onset of dyspnea, right? That will be acute heart failure, or there will be worsening of, right, or there will be worsening of the symptoms of the heart failure. That is what you see in case of acute heart failure, right? And this particular acute heart failure, how it occurs, or like it can be the consequence of, right? Remember, this acute heart failure episodes, they appear as a consequence of worsening of the chronic heart failure, right? It results from worsening of the chronic heart failure, right? But in 20% of patients, they may be due to new onset heart failure itself. That means the presentation itself is in the form of the acute heart failure in almost 20% of patients. And in this 20% of patients, what are the causes for this acute heart failure? So this acute heart failure, it occurs in the setting of, right, it occurs in the setting of the acute coronary syndrome. It occurs in the setting of valvular dysfunction. It occurs in the setting of hypertensive emergency, or it occurs as a part of post-cardiotomy syndrome, right? It occurs in the setting of post-cardiotomy syndrome. So these are the usual causes for the acute heart failure. Similarly, we have another terminology that is called as the acute pulmonary edema. So this acute pulmonary edema, it describes the clinical scenario in which the patients, they present with rapidly worsening signs and as well as the symptoms of the pulmonary congestion, right? Now, what will be the signs and symptoms of the pulmonary congestion? That will be acute onset dyspnea. And when you examine or when you auscultate these patients, right, the auscultation, you will listen the presence of bilateral basal crepitations, okay, bilateral basal crepitations, okay. And this acute pulmonary edema, it typically occurs due to, right, it typically occurs due to severe elevation of left heart filling pressures, right, left heart filling pressures, right. So this is about the acute pulmonary edema. Now then followed by that, you need to know the phenotypes and as well as the causes of the heart failure. As I have said you in the beginning itself, the etiology of the heart failure is being classified based on the ejection fraction of the individual. So the ejection fraction, it tells you about the contractility and as well as the output from the left ventricle. So the normal ejection fraction is like 55 to 70%, but near normal ejection fraction, that can be taken as more than or equal to 50%. So heart failure with reduced ejection fraction, where the ejection fraction of the individual is less than or equal to 40%, and whereas if you take the heart failure with preserved ejection fraction, here the ejection fraction is more than or equal to 50%. So more than or equal to 50%, we consider it as near normal or preserved ejection fraction, right? So now this reduced ejection fraction, what exactly happens in the heart? It is reduction in the systole. So it is the systolic heart failure. Whereas you take in case of the preserved ejection fraction. So in preserved ejection fraction, it is the diastolic heart failure, where the systole is being maintained properly, right? But this terminologies, that is diastolic heart failure and as well as systolic heart failure, these are the older terminologies. These are not being used in the recent times. So we classify the heart failure based on whether it is heart failure with preserved or whether it is heart failure due to reduced ejection fraction, right? Now, all these etiologies of the heart failure, they fall into these categories. That is coronary artery disease, right, where there will be decreased perfusion to the myocardium. Then the diseases within the myocardium itself, that is basically cardiomyopathies, right? Dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, or myocarditis, viral myocarditis, right? Then disorders within the pericardium like the constrictive pericarditis can cause the heart failure. Then pathology in the heart valves, usually the pathologies of the aortic valve and as well as the mitral valve, that will cause usually the left-sided heart failure, and pathologies in the tricuspid valve and pulmonary valve, they cause the right-sided heart failure. And the pathologies in the great vessels, okay. So like let us just assume systemic hypertension where the pressure within the aorta is more, like where the individual will land up in left heart failure, or pulmonary hypertension, the individual will land up in right heart failure. So great vessel pathologies, right? Now let us just classify the exact etiologies of the heart failure, that is what are the etiologies causing reduced ejection fraction and what are the etiologies causing preserved ejection fraction. So first you take the etiologies causing reduced ejection fraction. Coronary artery diseases where the patients with MI, that is myocardial ischemia or myocardial infarction, the contractility of the heart is reduced because the myocardium is infarcted, and thereby there will be reduced ejection fraction. And the other etiologies are valvular heart diseases, mainly like aortic regurgitation, mitral regurgitation, then congenital heart diseases, infections, non-ischemic cardiomyopathies, toxic cardiomyopathy, chronic lung or pulmonary vascular disorders, then the autoimmune diseases. Now let me just tell you what are the disorders under these subheadings we'll try to discuss. Now you take the coronary artery diseases. Coronary artery diseases, it includes number 1, myocardial infarction or myocardial ischemia, right? Myocardial infarction and myocardial ischemia. Then you take the valvular heart diseases. Valvular heart diseases, they causing reduced ejection fraction, that includes the aortic regurgitation, aortic stenosis, mitral regurgitation, they cause left heart failure, whereas tricuspid regurgitation will cause the right heart failure. Then congenital heart diseases, that includes the intracardiac shunt. And what are these intracardiac shunts? Like you take in patients with ventricular septal defect, at one point of time they develop pulmonary hypertension and they develop right heart failure, okay. So intracardiac shunt, then so these are the congenital heart diseases which will cause the heart failure. Next, infections, very very important, that is infections caused by Trypanosoma cruzi, that is the Chagas disease, and as well as the HIV. HIV usually it will cause cardiomyopathy and that makes the individual to land up in the heart failure. Then what are the etiologies that will cause non-ischemic cardiomyopathy causing heart failure with reduced ejection fraction? That includes number 1, tachycardia induced cardiomyopathy, right? Number 2, infiltrative disorders. Then familial disorders, right? Then what are the etiologies causing toxic cardiomyopathy with heart failure with reduced ejection fraction? Very important drug of abuse, that will be alcohol, and the next important drug will be cocaine. So these are the two important forms of abuse, and alcohol is the most common cause or most common toxin which will cause the heart failure with reduced ejection fraction by causing dilated cardiomyopathy. And then we also have some chemotherapeutic drugs, right? Doxorubicin, daunorubicin, these are the chemotherapeutic drugs that can cause the cardiomyopathy and causing heart failure. Then coming to the pulmonary disorders, the pulmonary disorders that includes pulmonary hypertension and as well as the cor pulmonale. And what are the autoimmune disorders? Autoimmune disorders, that includes the pathologies mainly in elderly individuals more than 50 years which will cause large vessel vasculitis, that includes giant cell myocarditis, right? Giant cell myocarditis. Then you take in patients with the SLE, in patients with SLE where the antibody is anti-nuclear antibody, right? But this anti-nuclear antibody in case of SLE is not specific, it is highly sensitive. But what is specific for SLE then? We have anti-Smith and as well as anti-DS DNA, right? So lupus myocarditis, right? So this will be an autoimmune disease which will cause the heart failure with reduced ejection fraction. Okay, right. Now after having discussed about the etiologies causing reduced, now let me tell you what are the etiologies that will cause the preserved ejection fraction, where the ejection fraction will be more than or equal to 50%, and these etiologies include the hypertension, then valvular heart diseases. What are those valvular heart diseases? I'll tell you. Then hypertrophic cardiomyopathy, then constrictive pericarditis, myocarditis, obesity, high output states. What are those high output states? I'll discuss that in detail. Then RCMP stands for restrictive cardiomyopathy. So remember, restrictive cardiomyopathy and hypertrophic cardiomyopathy, it will cause heart failure with preserved ejection fraction, whereas dilated cardiomyopathy, it will cause heart failure with reduced ejection fraction. Then radiation therapy, aging, and as well as endomyocardial fibroelastosis. These are the etiologies that will cause heart failure with preserved ejection fraction. Now out of which you take the valvular heart diseases, that includes the aortic stenosis that will cause heart failure with preserved ejection fraction. It can cause both preserved and as well as reduced as well. Then followed by that mitral stenosis. Cardiomyopathies, just now I was discussing, that is hypertrophic cardiomyopathy and as well as the restrictive cardiomyopathy. These are the etiologies that will cause heart failure with preserved ejection fraction. Then what are the high output states? The high output states, that includes number 1 anemia, then thyrotoxicosis, right, then B1 deficiency, that is beriberi, next AV fistula, next pregnancy, Paget's disease of bone, fever. So these are the high output states. Now you take anemia and as well as thyrotoxicosis, the heart rate increases in both of these conditions, anemia and as well as thyrotoxicosis, and that makes the individual to land up in heart failure. Then you take thiamine deficiency. See, thiamine is a very important vitamin which is required for synthesis of ATP, or which will provide a source of ATP within the myocardium. So when B1 deficiency is there, the myocardium will not receive adequate amount of the ATP and goes into a state of the failure. And AV fistula. Why AV fistula will cause heart failure with preserved ejection fraction? The reason is that, remember, whenever there is an AV fistula, whenever you are creating an AV fistula or whenever there is a congenital AV fistula, it is bypassing the capillaries. So the blood from artery is not going into capillaries. The blood from artery is directly entering into the vein. So usually what happens is, once the blood from artery reaches the capillary, some amount of the blood from the capillary or some nutrition or the energy, it goes into the peripheral organs, right? And then the venous circulation starts. That is what is normal. But here, whenever there is an AV fistula, what is happening here? So the blood is bypassing the capillary and the blood from artery is directly entering into the vein. From the vein, the blood enters into the heart. So now the heart, with every cycle, it is receiving excess amount of blood, right? And where the heart is not able to withstand that excess amount of blood with each cycle, and that the heart goes into a state of failure. That is the AV fistula mechanism causing the heart failure. Okay. Then coming to the myocardial and pericardial disorders, just now as I have discussed, myocarditis, usually viral myocarditis, and then pericarditis, that is the constrictive pericarditis, right? And okay, there is hypertrophic cardiomyopathy. What will be the etiology? Usually it is familial, and that too autosomal dominant type of inheritance is most common. Then you take restrictive cardiomyopathy, like the most common infiltrative disorder will be amyloidosis, and apart from amyloidosis, radiation, then myocardial fibrosis, then sarcoidosis, hemochromatosis, glycogen storage disorders. These are the cardiomyopathies that will cause heart failure with preserved ejection fraction. Okay, right. So after having discussed about the heart failure with reduced and preserved ejection fraction, now let me discuss about the heart failure with recovered ejection fraction. Now, what do you mean by this word recovered ejection fraction? See, a subgroup of patients who are diagnosed with heart failure with reduced ejection fraction, if they are being treated, right, if they are being treated with guideline directed medical therapy, right, if they are being treated with guideline directed medical therapy, they will recover their ejection fraction. Okay, so there will be rapid or gradual improvement in, right, rapid or gradual improvement in the ejection fraction of the patient. Now these particular group of individuals, they have been referred to as heart failure with recovered ejection fraction, right? Now what are the predictors of heart failure with recovered ejection fraction? The predictors include young age group of individuals. Young age, right, they'll have rapid improvement in the ejection fraction. Short duration of heart failure, right, some infectious pathology and you treated that infection, or some chemotherapeutic drug, you stopped that chemotherapeutic drug immediately. Okay, so right, short duration of the heart failure, that is also a very good predictor for the recovery of the ejection fraction. Then non-ischemic etiology, then small ventricular volumes and absence of the myocardial fibrosis. So these are the predictors of the heart failure with recovered ejection fraction. And if you take specific examples, like you take the non-ischemic cardiomyopathies, that includes the fulminant myocarditis, then stress cardiomyopathy, right? We learned this in the dilated cardiomyopathy, like we have a form of dilated cardiomyopathy called Takotsubo cardiomyopathy. So these patients with Takotsubo cardiomyopathy, when they are exposed to excessive stress, the apex is being ballooned out and the individual goes into a state of the heart failure. And once the stress of the individual recovers, or when the individual takes this aspirin and as well as the beta blockers, right, the ejection fraction of the individual recovers back, and that is also a specific example of the heart failure with recovered ejection fraction. Then peripartum cardiomyopathy, right? Peripartum cardiomyopathy, we have some common risk factors like preeclampsia, multiple pregnancies, and then increased age of the individual. So peripartum cardiomyopathy is also one of the etiology which is responsible for heart failure with recovered ejection fraction. Tachycardia induced cardiomyopathy, reversible toxin exposure such as chemotherapy, immunotherapy, and as well as the alcohol. So these are the specific examples that are responsible, that where we can see the rapid or gradual recovery of the ejection fraction in patients with heart failure with reduced ejection fraction when you treat them with guideline directed medical therapy, right? Now, so even though, right, there is recovery of the ejection fraction, patients still may be symptomatic. Why is that due to? That is because of persistent abnormalities in diastolic dysfunction, right? Persistent abnormality in the diastolic function of the individual, or persistent abnormality in, you take exercise induced pulmonary hypertension. So why they remain still symptomatic? That is because of, even though the ejection fraction is improving, still there might be a little amount of diastolic dysfunction. And now once the patient become asymptomatic, you should not stop the treatment, right? See, a heart failure with recovered ejection fraction, the symptoms will definitely try to reduce. Once the symptoms reduce, it is not that you should stop the treatment. So once you withdraw the treatment, so withdrawal of the therapy, that will lead to recurrence of the heart failure symptoms. Right, that will cause the recurrence of the heart failure symptoms, and there will be also decrease in the ejection fraction of the individual once you stop the treatment. So withdrawal of the treatment will cause recurrence of heart failure symptoms and as well as decrease in the ejection fraction of the individual. But you have to understand that in these patients with heart failure with recovered ejection fraction, the prognosis, it is superior, right? Prognosis, it is superior to heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Okay, that is what is the prognosis in heart failure with recovered ejection fraction. And we have another terminology called heart failure with mildly reduced ejection fraction. What is that? So in this, the ejection fraction of the individual is around 40 to 50%, that is more than 40% and less than 50%. And even these patients also they have to be treated with guideline directed medical therapy. So this is what is your heart failure with mild reduced ejection fraction, or this we come across in patients with heart failure with reduced ejection fraction. Once they are being treated with guideline directed medical therapy, they go into a state of heart failure with mildly reduced ejection fraction. Okay, and what do they have? The features, the clinical features, if you see, they have the clinical features of mild systolic dysfunction, right? They have the clinical features of mild systolic dysfunction, and along with that they also have the features of, right, along with that they also have the features of the diastolic dysfunction. Okay, so this will be the features of the heart failure with mildly reduced ejection fraction. Now you have to understand that unlike your American Heart Association and the Heart Failure Society guidelines, the ESC, that is European Society of Cardiology, is the one which has identified this heart failure with mildly reduced ejection fraction, right, where the ejection fraction of the individual is around 40 to 50%, right, 40 to 50%. Now among all the etiologies causing the heart failure, the most common cause of the heart failure will be the hypertension, right? Almost 75% cases of the heart failure are because of the hypertension. Next in the line comes the coronary artery disease, that is myocardial ischemia or myocardial infarction. Then diabetes mellitus, they constitute nearly around 10 to 40% of cases. But second most common cause will be the coronary artery disease, but the most common cause will be your hypertension, right? That is systemic hypertension, right? So if you take the etiologies causing heart failure in adults, right, that will be usually the acquired causes of the heart failure, okay, like the coronary artery disease, hypertension, valvular heart diseases, cardiomyopathies. Whereas you take the congenital and as well as the inherited disorders, most of the times, it is not always, most of the times the congenital and as well as the inherited disorders are the leading causes of heart failure in children and as well as the young adults, okay, as well as the young adults. Okay, so this is about the etiologies in adults and etiologies in children. Whereas you take in adults, right, whereas you take in adults with congenital heart diseases, what will be the pathophysiology in adults with congenital heart diseases causing heart failure? So they fall into one of the following three pathophysiological groups. Number one, uncorrected defects with late presentation due to misdiagnosis, non-intervention or lack of access to the care. Patient is having some VSD, patient is having PDA, patient is having ASD, the patient has not been diagnosed, or patient is having lack of access to the care, and the patient may directly present in a state of the right heart failure as a part of the Eisenmenger's complex, right? So uncorrected defects. Next, repaired or palliated defects with late valvular or the ventricular failure. What is this? Like for example, you take a child with congenital bicuspid aortic valve. That child goes into a state of aortic stenosis, and aortic stenosis presents with the heart failure. So repaired or palliated defects, and that particular bicuspid aortic valve has been treated with the help of valvuloplasty, but it is not being corrected properly, then that group of individual lands up in ventricular failure. Next, failing single ventricle physiology. So in adults with congenital heart diseases who develop heart failure can be divided into one of these three pathophysiological groups. And if you see the overall etiologies, right, this is the division, or this is the division of the percentage wise etiologies in men and as well as in women. So most common cause, what did I tell you? Hypertension, then followed by that myocardial infarction, then followed by that diabetes mellitus. Either you take men or you take women, the most common cause will be the same, that is the hypertension, second will be myocardial infarction, and third will be diabetes mellitus, right? Now apart from these, we have some inherited cardiomyopathies which are responsible for the development of the heart failure. And these inherited cardiomyopathies, that includes the ARVD, that is arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic right ventricular dysplasia, where right ventricular myocardium is replaced by the fibrofatty tissue. And the other one already I have discussed, it is an autosomal dominant type of inheritance, that is hypertrophic cardiomyopathy. Then we have some muscular dystrophies, and these muscular dystrophies, they are responsible for dilated cardiomyopathy, like Duchenne's muscular dystrophy or myotonic dystrophy. They cause dilated cardiomyopathy causing the heart failure. Then we have some mitochondrial disorders or mitochondrial myopathies, right, like Kearns-Sayre syndrome, right? So mitochondrial disorders. So these are the inherited cardiomyopathies that are responsible for the development of the heart failure. And now you take the familial cardiomyopathies. Most of these familial cardiomyopathies, what is the mode of inheritance? The mode of inheritance is most commonly it is the autosomal dominant form of inheritance, right? Then you take in young individuals of Asian origin or the African origin, what is the common cause of heart failure? See, in adults we have discussed it is the hypertension definitely, whereas if a young individual is presenting with a state of the heart failure, then what would be the most common cause? That would be the rheumatic heart disease, right? Rheumatic origin valvular pathology, or rheumatic origin myocarditis, or rheumatic origin pericarditis, right? Then we have discussed that the high output states, anemia, thyrotoxicosis, beriberi, AV fistula, Paget's disease of bone, fever, pregnancy, in all of these individuals, remember, there may be or there might be absence of, right, there might be the absence of the underlying structural heart disease, right? There might be absence of underlying structural heart disease, right? Then, so that was about your etiology and classification of the heart failure. Now let me discuss the basic pathophysiology of the heart failure. So heart failure with reduced and preserved ejection fraction, pathophysiologies are separate, when they are different, I'll explain to you separately. But let me first take up the discussion of heart failure with reduced ejection fraction. So heart failure with reduced ejection fraction, it is a progressive disease that typically involves an index event. That means there will be one acute episode, and after that, or there will be one etiology causing the heart failure, and that will be followed by, right, that will be followed by months to years of structural or, right, structural or functional cardiovascular remodeling, right, structural or functional cardiovascular remodeling. So in the pathophysiology, just important that etiology causing the heart failure is not important for us. That particular etiology, which is the index event, how is it causing the structural and functional cardiovascular remodeling, that understanding is very important for us to give the specific treatment, right? And this particular index event or the primary event, it may be sudden in onset. Where do you have this sudden in onset of heart failure? Like you take in patients with acute myocardial infarction, or it might be, right, or it might be gradual in onset. Where can you have this gradual in onset? That is in patients with cardiomyopathies, or you take in patients with the congenital heart diseases, okay, or you take pressure overload conditions like hypertension or the aortic stenosis. So it might be gradual. So the primary event, it might be either acute or gradual in onset, right? But what is very important is the consequence of that primary event is very, very important, right? So despite an initial reduction in the cardiac performance, patients may be asymptomatic or mildly symptomatic. Why and how? Even though there is reduction in the cardiac performance, why is that the individual is asymptomatic? The reason is because of the activation of the compensatory mechanisms. Right? Activation of this compensatory mechanisms, right? And what are these compensatory mechanisms? These compensatory mechanisms include, number one, activation of the sympathetic nervous system. Number two, activation of renin-angiotensin aldosterone system. Number three, non-osmotic release of the antidiuretic hormone. So these are the compensatory mechanisms that makes the individual being mildly symptomatic or asymptomatic, right? Now let me just give you the sequence of events that will happen, and why that particular events happen I'll be discussing in this pathophysiology. So now in these patients there is either systolic or the diastolic dysfunction that develops, and that could be because of the index event, right? That is either acute event or the chronic event. Now this particular systolic or diastolic dysfunction, this is occurring as a part of a stimuli that is nothing but the index event, and because of that systolic and diastolic dysfunction, the individual is developing an increased wall stress. Why is this increased wall stress? That is because of your ventricular enlargement, right? Then actually all these events, they are in the form of a vicious cycle. One particular event starts first, then consequently there will be systolic, the systolic or diastolic dysfunction, and that will progress to, there will be remodeling stimuli. See, once there is, what did I tell you just now? There is activation of the compensatory mechanisms, and these compensatory mechanisms, they increase the wall stress. Why? Because your sympathetic activation of RAS, they will increase the afterload on the heart and increasing the wall stress. And there is also the release of the inflammatory mediators that includes cytokines, and there will be neurohormonal oxidative stress. So all these events will cause myocyte hypertrophy, altered intestinal matrix, fetal gene expression, altered calcium handling proteins, and finally myocyte death. So these are the events that will be progressing the individual in the severity of the heart failure. Now let me try to discuss all these, how they are happening, why they are happening, and what will be the consequence of this, and how can we inhibit this, right? So you have to understand that first and foremost, very important, there is ventricular remodeling, and this ventricular remodeling, it occurs in response to, right? So different patterns of ventricular remodeling, it occurs in response to excess cardiac workload, right? In response to excess cardiac workload, either it might be because of hypertension or it might be because of the aortic stenosis, whatever it might be. Like you take in patients with the pressure overload, if this excess cardiac workload, if it is in the form of pressure overload, the cardiac remodeling that happens is the concentric hypertrophy. Okay, so concentric hypertrophy, in which increased mass is out of proportion to the chamber volume. What will be the reason or the etiologies causing concentric hypertrophy or the pressure overload conditions? The pressure overload conditions include hypertension, then the aortic stenosis, or this cardiac remodeling can occur in the form of eccentric hypertrophy as well. And this particular eccentric hypertrophy, there will be, volume overload conditions, where there will be increase in the size of the cavity, right? Increase in cavity size or the volume. This will be like volume overload conditions. Okay, and these volume overload conditions include the aortic regurgitation, and these volume overload conditions include the mitral regurgitation. So pressure overload conditions will cause remodeling in the form of concentric hypertrophy. Volume overload conditions will cause cardiac remodeling in the form of the eccentric hypertrophy, right? And in both the forms of remodeling, what is happening? There is increase in the ventricular mass. Either you take concentric or you take the eccentric hypertrophy. Definitely there is increase in the ventricular mass. And increase in this ventricular mass is accompanied at the cellular level, right? And increase in the ventricular mass, it is accompanied at the protein level and as well as at molecular level. So you take at cellular level, what are the remodeling or what are the changes that is happening within the myocyte? At the cellular level, there is myocyte hypertrophy and interstitial fibrosis. This will be the changes at the cellular level. Now you take at the protein level. At the protein level, there is alteration in calcium handling, right? There is alteration in the calcium handling and alteration in cytoskeleton function, right? Alteration in the cytoskeletal function. Then you take at molecular level. At the molecular level, by the expression of the fetal genes. See, excessive expression of the fetal genes will cause impairment of the calcium handling and that will cause the cardiac remodeling. So at cellular level, it is hypertrophy and fibrosis. At the protein level, impairment of the calcium handling and cytoskeletal function, and at molecular level, re-expression of the fetal genes, right? Now, in these myocytes, definitely there is necrosis of the myocytes. So in addition to the cell loss because of the necrosis, myocytes that are unable to adapt to remodeling stimuli may be triggered to undergo apoptosis, right? Myocytes that are unable to adapt to the remodeling stimuli, they may be triggered to undergo apoptosis or programmed cell death, right? So these are the changes that is happening at the cellular level or at the molecular level. That means what will be the effect of these changes or what is the mechanism within the myocyte? Like if you see the mechanism of the ventricular remodeling, just now I have discussed what are the changes that happens at the level of the myocyte, that is myocyte hypertrophy and as well as the interstitial fibrosis. Now what are the mechanisms of that ventricular remodeling? Number one, change in the myocyte biology. There is changes in the myocardial makeup. There will be changes in the ventricular geometry. Now these changes makes the individual to progress the severity of the heart failure. See, actually initially there will be only an index event, but consequent to that index event, there is remodeling that is happening and that will make the individual to progress the heart failure. Okay. Now the changes in the myocyte biology. Number one, there will be abnormal excitation contraction coupling and as well as cross-bridge interaction. That is one change in the myocyte biology. Next, fetal gene expression. Number 3, beta adrenergic receptor desensitization. Number 4, myocyte hypertrophy. Number 5, impaired cytoskeletal proteins. So these are the changes in the myocyte biology. Then you take the changes in the myocardial makeup. Changes in myocardial makeup include myocardial necrosis, apoptosis and the autophagy. Then interstitial and perivascular fibrosis. And next followed by that, the matrix degeneration. Then there are also changes in the ventricular geometry that includes ventricular dilatation and as well as thinning of the ventricular wall. Then increased sphericity and displacement of the papillary muscles, and then finally atrioventricular wall regurgitation. So these are the three mechanisms of the ventricular remodeling: changes in myocyte biology, changes in myocardial makeup, changes in the ventricular geometry. Okay, so these are the mechanisms causing ventricular remodeling and as well as the progression of the heart failure, particularly in heart failure with reduced ejection fraction, right? Whereas you take in scenario of the heart failure with preserved ejection fraction, what exactly are the reasons for the ventricular remodeling? It is not very clear, but what has been described, okay, what is, see, preserved ejection fraction is nothing but diastolic dysfunction, right? Preserved ejection fraction is nothing but diastolic dysfunction. So if you see the description of heart failure with preserved ejection fraction, why there is diastolic dysfunction? The primary mediator of the heart failure signs and symptoms in case of the diastolic dysfunction is impairment of uptake of cytosolic calcium, where at the myocyte level. So at the myocyte level, there is impaired uptake of cytosolic calcium into the sarcoplasmic reticulum, right? Why there is impaired uptake of cytosolic calcium into the sarcoplasmic reticulum? Because of reduction in the ATP, right? Because of reduction in adenosine triphosphate, and because of this impaired uptake of cytosolic calcium, that will cause abnormality in myocardial relaxation, right? That will cause abnormality in myocardial relaxation. So this is about the pathophysiology in preserved ejection fraction, and these three are the important mechanisms for ventricular remodeling in heart failure with reduced ejection fraction: myocyte biology abnormality, myocardial makeup abnormality, then ventricular geometry abnormality, right? Then if you see the mechanisms of the disease progression, whatever we have discussed until now, they are the changes, and that particular changes also are responsible for the progression of the disease of the heart failure. But in this mechanisms of the disease progression, I'll be telling you what are the reasons or what are the mechanisms for these changes, right? There is impairment of cytosolic calcium into the sarcoplasmic reticulum. Why? Right? There is abnormality in the myocyte biology, changes in myocardial makeup, changes in ventricular geometry. Why? That I'll be discussing now in this mechanisms of disease progression. So in this mechanisms of disease progression, I'll be discussing in detail about the compensatory mechanisms, right? I'll be discussing in detail about the compensatory mechanisms. So a number of compensatory mechanisms, they become activated during the development of heart failure and they contribute to the disease progression. And one of the very, very important compensatory mechanism is the neurohormonal activation. So in this neurohormonal activation, there is activation of sympathetic nervous system and there is activation of the renin angiotensin aldosterone system. So these two, they are responsible for, or they play a critical role in the development and as well as the progression of the heart failure, right? Progression of the heart failure. Now in this particular neurohormonal activation, why is it activated? Let me explain you the mechanism. So in heart failure, there is decrease in cardiac output. That will cause decrease in the blood pressure and that is being sensed by the baroreceptors. And what are these baroreceptors? That is carotid sinus and as well as the aortic sinus. They sense that there is fall in the blood pressure, or whenever there is decrease in blood pressure, there is also decrease in the renal perfusion. Once there is decrease in the renal perfusion, there will be activation of the RAS, renin angiotensin aldosterone system. And that will cause the release of the aldosterone and that will also cause the release of the angiotensin 2, right? So these will be one important compensatory mechanism, because aldosterone will cause sodium and water retention and angiotensin 2 will cause vasoconstriction and thereby the blood pressure is being maintained. So even though the individual is developing heart failure, in early stages the individual is mildly symptomatic or asymptomatic. And once the baroreceptors are activated, right, they will stimulate the vasomotor center which is present in the medulla oblongata, and it will increase the sympathetic outflow, and that will cause the vasoconstriction and thereby improvement in the blood pressure of the individual. Okay, so this will be the reasons or mechanisms of the neurohormonal activation. Now, as the time progresses, if these compensatory mechanisms are unchecked, that will lead to excessive vasoconstriction, right? Why is this? That is mainly because of activation of sympathetic nervous system, and that will increase the afterload on the ventricles. Okay, that is one thing. And second important abnormality that happens is the volume retention. Why is that? That is because of excessive release of the aldosterone, and this will increase the preload. PL stands for preload on the heart, and there will be also electrolyte abnormality, right? And that electrolyte impairment or abnormality, that is mainly because of the release of the aldosterone, where there will be excessive sodium and as well as water retention, causing the fluid overload. Okay, and all these changes will make the individual to develop or to have myocardial or cardiac impairment. And this myocardial impairment, they are the one, right? This myocardial impairment, they are the one which will precipitate the individual to develop the arrhythmias, which will precipitate the individual to develop cardiac arrhythmias, and where the individual can have even a sudden cardiac death as well. Okay, and you take at the tissue level, the neurohormonal activation, it contributes to remodeling of the heart. Okay, and it will contribute to the remodeling of the blood vessel, it contributes to the remodeling of the kidneys, and it contributes to the remodeling of the various organs. Now, why the kidneys and other organs are getting affected? That is because of decreased organ perfusion, because of decrease in cardiac output. So remodeling changes also starts even in the other organs as well. Okay, now, so this neurohormonal activation, is it good or bad? Now, initially we feel that the blood pressure is improving and the individual is being asymptomatic and the individual is mildly symptomatic. Initially or transiently, these compensatory mechanisms are good. But in long term, these compensatory mechanisms are increasing the preload and increasing the afterload on the heart. They will further precipitate the heart failure. So because of increase in preload and because of increase in afterload, these are the reasons why the changes happen at the level of the ventricle, and that will contribute to the reduced and as well as the preserved ejection fraction. What are the changes we have discussed? Abnormality in the myocyte, abnormality in the myocardial makeup, right? Abnormality in the myocardial geometry, right? And impairment of the calcium intake into the sarcoplasmic reticulum, causing heart failure with preserved ejection fraction. So all those changes are mainly because of this increased or excessive neurohormonal activation. So that is the reason why there have been many trials which have been done to inhibit these compensatory mechanisms, because these compensatory mechanisms in long term, they are causing the myocardial remodeling. So that is the reason why the many trials have been tried to inhibit the RAS. And how is this particular RAS being inhibited? That is by the ACE inhibitors or angiotensin receptor blockers or mineralocorticoid receptor antagonists like the spironolactone and eplerenone, and the beta blockers, particularly the cardioselective beta blockers like metoprolol, and the other beta blockers are bisoprolol and as well as metoprolol, carvedilol, which are very important in heart failure. So whenever these neurohormonal activations have been inhibited or once they have been neutralized, it has been found in the studies that they will reverse, right? They will reverse ventricular, right? They will reverse ventricular and vascular remodeling. Right? They will reverse ventricular and vascular remodeling and thereby reduces mortality and as well as it reduces the morbidity as well. Okay. So these neurohormonal activation in long term, it is not good. So you need to definitely neutralize that. So if you see the sequence now, there is cardiac impairment, baroreceptor dysfunction is there, right? There is vasomotor center activation causing increased sympathetic outflow, causing increased vasopressor, that is antidiuretic hormone release, and at the same time there is, because of excessive vasoconstriction, there is reduced blood supply to the kidney, and not only that, because of decrease in cardiac output also there is reduced blood supply to the kidney, and there is also reduced blood supply to the limb where there can be digital ischemia, and once there is reduced blood supply to the kidney, that will cause the activation of RAS, where there will be excessive release of the aldosterone. And why this angiotensin 2 is the one which will go and act on the adrenal cortex, that is zona glomerulosa, and that will cause the release of the mineralocorticoid, that is aldosterone, which will cause sodium and water retention, and that will increase the preload on the heart. So like once there is increase in the preload on the heart, that will cause cardiac remodeling, and further the heart failure progresses, and further there will be decrease in cardiac output, and further there is activation of baroreceptors, or further there is activation of sympathetic outflow, and further there is activation of RAS again. So this is a vicious cycle. Now this neurohormonal activation is not good, right? So these neurohormonal activation, it has to be completely neutralized, and for that we need to give the ACE inhibitors or ARBs, and we need to give the beta blockers. Now apart from these group of drugs, that is ACE inhibitors, beta blockers, ARBs, and mineralocorticoid receptor antagonists. So now in the pathophysiology, I am trying to discuss even the treatment as well. I am trying to correlate the treatment as well. Okay. So if the question is asked, like what are the group of drugs which will reduce the mortality and morbidity in patients with heart failure? Beta blockers, mineralocorticoid receptor antagonist, ACE inhibitors, or the angiotensin receptor blockers, and we have few more drugs. I'll discuss them. Then coming to the vasodilatory hormones. Now you take RAS and as well as sympathetic nervous system activation, they contribute to disease progression in heart failure by a number of counter-regulatory hormones that are being upregulated. And these RAS and as well as sympathetic nervous system activation, they cause initially the beneficial effect, and later there will be harmful effect on the heart. Right? Initially beneficial effect, and later the harmful effect on the heart. Right? Now we want some vasodilatory hormones in order to counter that vasoconstriction. Because of excessive sympathetic activity and because of angiotensin 2, there is vasoconstriction that will worsen the heart failure. And the release of these vasodilatory hormones, these are the counter-regulatory hormones. And these particular counter-regulatory hormones, they include number one, natriuretic peptides, that is atrial natriuretic peptide and as well as brain natriuretic peptide. Then the other counter-regulatory hormones are prostaglandins, prostacyclins, bradykinin, adrenomedulin, and as well as the nitric oxide. What these drugs do, or what these substances do, you take this bradykinin. Bradykinin, it will elevate or increase the vascular permeability, and thereby it will reduce the systemic venous congestion. And not only that, it is also having vasodilatory property, and that will reduce the afterload on the heart. Then you take this prostacyclin, which is nothing but your PGI2. They also have the relaxation effect on vascular smooth muscle, and thereby it will cause vasodilatation of the pulmonary arteries. Right? Thereby there will be vasodilatation of the pulmonary arteries. Right? Then you take this prostaglandins, even they also cause the vasodilatation. And then you take this adrenomedulin. Adrenomedulin, it's a potent long-standing vasodilatory agent. Right? Long-standing vasodilatory agent, and thereby it also will reduce the afterload on the heart. Nitric oxide is also vasodilatory agent. This natriuretic peptides, what they will cause? They will cause the natriuresis, because in patients with the heart failure, because of release of angiotensin 2, that will cause aldosterone release, which will cause sodium and water retention, which will increase the fluid overload and increase the preload. We don't want that. Okay. So whenever because of excessive atrial stretch, there will be release of atrial natriuretic peptide. Because of excessive ventricular stretch, there will be release of the brain natriuretic peptide. So these are the counter-regulatory hormones which are being released in order to have the beneficial effect, right? In order to have the beneficial effect on the heart. And these particular beneficial effects are mediated through stimulation of the guanylyl cyclase and include systemic and pulmonary vasodilatation, right? So by causing vasodilatation, there will be decrease in afterload on the right ventricle and as well as the left ventricle, and increased sodium and water excretion by the natriuretic peptides, inhibition of RAS and as well as the aldosterone, that is by your ACE inhibitors, ARBs or aldosterone antagonists, and baroreceptor modulation, that is by giving the beta blockers or alpha plus beta blocker, that is carvedilol. So beneficial action is being mediated through the following mechanism. Okay, right. Now if you take the bradykinin, I said you already, it will cause vasodilatation. Natriuretic peptide, it will cause the release of the natriuresis. Okay, now but these are the important substances now. Bradykinin and natriuretic peptides are very, very important substances in patients in heart failure to prevent the progression of the heart failure. But these bradykinin and natriuretic peptides, they are inactivated by a substance called neprilysin. Okay. Now, is this and what is this neprilysin? Neprilysin, it's a membrane bound peptidase. Right, it's a membrane bound peptidase. Now, what is the role of this neprilysin? It is not good to the heart now because it is neutralizing the natriuretic peptide and as well as bradykinin. So, do you want this neprilysin in case of heart failure? No, we give neprilysin inhibitors. Okay, so we have the recent new trials. That particular trial is Paradigm HF trial. So in Paradigm HF trial, there was the use of neprilysin inhibitor, and the example of the neprilysin inhibitor is the sacubitril. So when you give the sacubitril, that will inhibit this neprilysin, which is a membrane bound peptidase, and thereby that will increase the sacubitril will increase the bradykinin and as well as the natriuretic peptide. By increasing the bradykinin, there will be vasodilatation, decreasing the afterload on the heart, right? And by releasing natriuretic peptide, there will be natriuresis and thereby reducing the preload on the heart. Okay, so this is about the importance of giving neprilysin inhibitors. Okay, so the next important discussion in this pathophysiology is the endothelin, inflammatory cytokines and oxidative stress. How do they contribute to this heart failure and how does it progress? Let me discuss. So this endothelin, it is a potent vasoconstrictor peptide. And this endothelin not only has the vasoconstrictor activity, it also has growth promoting effect. And this growth promoting effect and as well as the vasoconstrictor effect, it is potentially seen in the pulmonary arteries. And because of vasoconstrictor and growth promoting effect in the pulmonary arteries, that will make the individual to develop the pulmonary hypertension, and that makes the individual to go into a state of right ventricular failure. And these endothelins, where are they being released from? It is released from a variety of vascular and the inflammatory cells within the pulmonary circulation and as well as the myocardium, right? And this endothelin, whichever is being released, what is it causing? It is causing vasoconstriction, and it is also causing the growth promoting effect within the pulmonary artery. What that will cause to the myocardium? That will increase the afterload on the right ventricle, and that will cause right ventricular myocyte hypertrophy. That will be the changes in response to the endothelin which is being released. And not only that, there can be also development of the interstitial fibrosis. So whenever there is underlying etiology causing the heart, for example, you take infarction, where the blood supply to the myocyte is being reduced and there is a death of the myocardium, and there will be infiltration of these inflammatory cells at that point. And that inflammatory cells and a variety of vascular stimuli will cause the release of endothelin, that will cause pulmonary artery vasoconstriction or pulmonary artery overgrowth, vascular lumen overgrowth, and that will cause afterload on the right ventricle, causing myocyte hypertrophy and as well as the interstitial fibrosis, right? Now, for neurohormonal activation, we are giving RAS inhibitors and we are giving sympathetic nervous system inhibitors, okay? In the similar way, endothelin blockade, right? In a similar way, the endothelin blockade has been shown to slow the progression of the clinical heart failure, but it is beneficial to treat the pulmonary hypertension only. So endothelin blockers, they are useful only for the treatment of pulmonary hypertension only, right? Not overall the heart failure. So by treating pulmonary hypertension, it will be very much useful in the treatment of right heart failure secondary to pulmonary hypertension, but not for the left heart failure. Now, coming to the inflammatory mediators or the inflammatory cytokines. So I said you, a process of the inflammation starts at the level of the myocardium because of the infarction or many other underlying etiologies. And what are these inflammatory mediators? So the other factors that have the potential to cause or contribute the ventricular remodeling in heart failure include the inflammatory cytokines. And these inflammatory cytokines, that includes tumor necrosis factor alpha, that is TNF alpha, then interleukin 1 beta and reactive oxygen species such as the superoxide. Okay, reactive oxygen species such as the superoxide. These are the inflammatory cytokines which are being released, and that will also contribute to the ventricular remodeling, right? And these particular changes, okay, the potential sources of these biologically active substances, that is the inflammatory mediators, they are the liver and as well as the gastrointestinal tract. These are the sources of these biologically active substances. Now, because there is release of the inflammatory mediators that are making the individual to progress the heart failure, whether to give anti-inflammatory drugs or whether to give antioxidant therapies, that still remains unproven. The studies did not give any particular benefit saying that anti-inflammatory drugs or antioxidants will help in reducing the mortality of the individual. Now, there are some novel biological targets. There are new targets. Examples like SGLT2, that is sodium glucose cotransporter 2. Where is it present? It is located on the proximal tubule of the kidney. And this particular SGLT2, it's a protein which is located on the proximal convoluted tubule of the kidney. What is it responsible for? This is responsible for reabsorption of 90% of glucose from the proximal convoluted tubule. That is a basic function of this SGLT2. And in patients with heart failure, the activity of SGLT2, it contributes to, right, it contributes to sodium and as well as the water retention. And not only that, this SGLT2 will also cause endothelial dysfunction. Right, this will also cause endothelial dysfunction. And third important, there will be abnormal myocardial metabolism that will happen in response to, right, abnormal myocardial metabolism in response to the SGLT2. And this SGLT2 will also cause impairment of the calcium handling. Right, impairment of the calcium handling. Okay, so these are the changes that occurs because of the SGLT2 in patients with the heart failure. Now we need to give the group of drugs which will inhibit this particular SGLT2. So the inhibitors of SGLT2 were developed for the treatment of the heart failure, and this particular group of drugs actually were given in the treatment of type 2 diabetes mellitus. So when you are giving in patients with heart failure, so all these effects of the SGLT2 will be neutralized, and thereby it will reduce the mortality in patients with the heart failure. And similarly, by inhibiting the SGLT2, the glucose reabsorption does not occur, and thereby it will be also useful in the treatment of the type 2 diabetes mellitus as well. So in type 2 diabetes mellitus, the advantage of the glycosuric effect will be helpful. But the problem with these group of drugs is they are more prone for the development of the urinary tract infection. Why? Because more and more glycosuria, more and more bacteria are attracted into the urinary tract, the more and more urinary tract infection. Okay. right? So what these particular trials, many trials have shown that the cardiovascular disease, including heart failure with reduced ejection fraction, particularly heart failure with reduced ejection fraction, it has been found to be beneficial to give SGLT2 inhibitors in improving the outcome of the individual and in reducing the mortality and as well as morbidity in patients with the heart failure, right? Now, another important pathway which is very much important to be taken care is, that is another pathway that is downregulated in heart failure and contribute to the endothelial dysfunction involves cyclic guanosine monophosphate. Okay, so this cyclic guanosine monophosphate, that is also the one which will contribute to the development of the endothelial dysfunction. So what is this? Downregulation of the cyclic GMP is what is responsible for endothelial dysfunction. So what you need to give now? You need to give oral soluble guanylate cyclase stimulators. What are the examples of this? That includes the riociguat. So this particular riociguat, it's an oral soluble guanylate cyclase stimulator. What this does? This riociguat, it enhances the cyclic GMP pathway, right? It will improve the cyclic GMP pathway, and that will exhibit or exert the beneficial effects on the myocardium, right? That will exhibit the beneficial effect on the myocardium. Okay, right? So this is about your oral soluble guanylate cyclase stimulator, and this riociguat, it is mainly used in the treatment of the pulmonary hypertension. So thereby this riociguat is useful where mainly in patients with right ventricular failure secondary to pulmonary hypertension, this riociguat will be very much useful. And another important abnormality that happens within the heart in patients with heart failure is dysynchrony and as well as the electrical instability. In up to 1/3 of patients with heart failure, the disease progression is associated with prolongation of the QRS complex. So you will have a wide QRS complex where the QRS complex will be more than 120 milliseconds. So when the QRS complex is more than 120 milliseconds in a patient with heart failure, what does that tells you? That tells you that there is dysynchrony within the ventricular contraction. So there is intraventricular dysynchrony and there is also electrical instability. So the electrical dysynchrony, it is in the form of the left bundle branch block or it is in the form of intraventricular conduction delay, right? Intraventricular conduction delay. So these are the two forms of the electrical dysynchrony that results in abnormal ventricular contraction. That results in abnormal ventricular contraction. Now, the correction of the electrical dysynchrony, how is it done? It is by left ventricular pacing, right? Or you need to do biventricular pacing. So, by doing this left ventricular pacing or biventricular pacing, the electrical dysynchrony is being corrected. And once this dysynchrony is corrected, there will be improvement in the contractile function of the individual, right? There will be improvement in the contractile function of the heart, and there will be also decrease in mitral regurgitation in the individual if mitral regurgitation has developed, and thereby there will be reversal of cardiac remodeling. That is the advantage of left ventricular or biventricular pacing. Okay, so dysynchrony and electrical instability, if it develops, that will further precipitate the heart failure. Okay, so in patients with symptomatic heart failure with reduced ejection fraction in left bundle branch block on guideline directed medical therapy, CRT, that is cardiac resynchronization therapy, is indicated to reduce, right? It is indicated to reduce the mortality and as well as it will reduce the morbidity in patients with the heart failure with electrical dysynchrony, right? And the other forms of electrical instability, it includes the development of the arrhythmias. So if there is development of atrial fibrillation what can happen? That will cause reduced ventricular filling, or another important form of electrical instability will be in the form of frequent premature ventricular contractures. So the electrical instability in the form of atrial fibrillation, electrical instability in the form of premature ventricular contractures, even they also contribute to the worsening of the heart failure. They also contribute to the worsening of the heart failure, right? Next, although the direct impact of tachycardia and irregular rhythm on disease progression, it is being linked, right? It is in the form of a vicious cycle. So because of the compensatory mechanisms, there is tachycardia and as well as the irregular rhythm, and that is what is contributing to the development of the arrhythmias. And not only these arrhythmias, they are causing the heart failure, and that is again causing the activation of the compensatory mechanisms. These compensatory mechanisms will cause ventricular remodeling, and these ventricular remodeling will cause again development of the arrhythmias. Okay, so this is a form of the vicious cycle, right? So you need to cut down this tachyarrhythmias, and you also need to cut down these compensatory mechanisms as well as a part of the treatment, right? So this is about the electrical dyssynchrony and as well as the instability. Now these patients with the heart failure, they develop what is called as secondary mitral regurgitation, right? And a number of mechanisms have been demonstrated, right? So a large number of patients with heart failure with reduced ejection fraction demonstrates the evidence of this mitral regurgitation. Now what are the various mechanisms? So there are totally 5 important mechanisms. Number 1, distortion in the mitral valve apparatus. Okay, so the distortion of the mitral valve apparatus, what all it see, mitral valve apparatus, what all it includes? One is mitral leaflets, anterior and posterior mitral leaflets. Next is the mitral valve annulus. Then we have chordae tendineae. Next we have papillary muscles. Then we have the entire endocardium. So these are the structures within the mitral valve apparatus where there will be distortion of the mitral valve apparatus causing mitral regurgitation. Now there will be also reduced contractile force in case of heart failure with reduced ejection fraction. So once there is reduced contractile force, that will lead to reduction in coaptation of mitral leaflets, right? That will cause reduced coaptation of the mitral leaflets, that will contribute to the development of mitral regurgitation. And next important thing is the shape of the ventricle. The spherical shape of the ventricle, it influences, right? It influences the length and as well as the function of the chordae tendineae and as well as the papillary muscles. So the spherical shape, which is like developing as the sequence or as the progression of the heart failure, will disturb the mitral valve apparatus, and that will contribute to the mitral regurgitation. And there is also increased dimension of the mitral annulus, right? And this increased dimension of the mitral annulus, like for example as a part of dilated cardiomyopathy. So once there is increased dimension of the mitral annulus, that will cause reduced leaflet alignment, right? That will cause reduced leaflet alignment. Then followed by that, there will be also dilatation of the posterior wall of the left atrium. Once there is dilatation of the posterior wall of the left atrium, that will cause the distortion of the posterior mitral leaflet. Okay, so these are all the various mechanisms for the development of secondary mitral regurgitation in patients with the heart failure. And you have to understand that the heart failure will further progress when there is worsening of the regurgitation. So this worsening of the regurgitant volume, that will cause progression of the heart failure. Okay, so this is very important abnormality that is happening in patients with the heart failure. And what has been found is, if you treat this particular mitral valve, so when the individual is in a state of the heart failure, you give him guideline directed medical therapy. After giving this guideline directed medical therapy, you treat the patient by transcatheter mitral valve. So you treat by transcatheter techniques. Right, you treat by transcatheter techniques. So this transcatheter techniques on the mitral valve, they have been found to be successful in reducing the mitral regurgitation and thereby reducing the progression of the heart failure. Okay, so this is about the mitral regurgitation and how to handle this mitral regurgitation. First treat by guideline directed medical therapy, and then followed by that transcatheter mitral valve technique should be followed. Then followed by that, the another important abnormality that develops in heart failure is the congestion of the gut. And so how is this congestion of the gut being developed is, as a part of the right ventricular failure, there is impairment of the venous drainage into the superior mesenteric vessels, and that will contribute to the gut congestion. Okay, so not only that, circulating levels of the pro-inflammatory cytokines are elevated in number of cardiovascular diseases, including heart failure, that have been associated with the disease progression, right? And you take the, what exactly is the primary source of inflammation is not known, but the emerging evidences suggest that there is an alteration in the gut microbial flora. This alteration in gut microbial flora, that is playing an important role in this process of inflammation. What is the primary source? We don't know. But there is also alteration in the gut microbial flora composition, and there is also loss of microbial diversity that also plays an important role, right? And what exactly is the reason for the gut congestion? We have discussed. One includes altered microbial composition, and the other important events just now as we have discussed, that is because of right ventricular failure, and due to which there is impairment of the venous drainage from the gut into the superior mesenteric artery, right? Now this gut flora also releases some important substances that also contribute to the venous congestion, or that also contributes to the gut wall edema. Example, lipopolysaccharide. Lipopolysaccharide, it's a gram-negative bacterial cell wall product, and these levels, they are increased in patients with the heart failure, and these particular lipopolysaccharide that will be responsible for, so this particular lipopolysaccharide, it is a gram-negative bacterial cell wall. It is the product whose levels are increased in patients with the heart failure, and this can cause increase in the intestinal permeability, right? This can cause increase in the intestinal permeability during the periods of congestion and reduced with the diuretic treatment. So for the congestion, what is the treatment that you need to give? Diuretics. Okay, and these patients, because of the congestion, they present with the diarrhea, and they also present with the vomiting as well, right? And but the problem with this lipopolysaccharide is that lipopolysaccharide, it is a strong stimulator of the immune system. Because it's a strong stimulator of the immune system, that will lead to dysregulated systemic inflammation, right? Dysregulated systemic inflammation via the macrophage activation, right? Now there will be also release of the cytokines we have discussed. What are those cytokines? That includes the TNF alpha, then the interleukin 1, and as well as the interleukin 6. So even these cytokines, they also cause progressive loss of the cardiac function, right? They also cause the progressive loss of the cardiac function, and that will also contribute to the development of the cardiac cachexia, right? So this is about the cytokines, and as well as the gut wall edema, and as well as the microbial flora. And lastly, the high output states. So high output states, I have said you, that is anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy and fever. these patients, in these individuals, they can have either reduced or preserved ejection fraction, right? And thereby there will be abnormality within the cardiac output, and that is accompanied by elevated vascular resistance. Okay, and this increase in the vascular resistance, that will contribute to the heart failure. So as such, in these patients with high output states, there is no abnormality within the heart. There is no structural pathology within the heart. But these high output states, they, along with elevated systemic vascular resistance, contribute to the heart failure. Okay. So basically, they precipitate the heart failure. And patients with end-stage renal disease, they are particularly at risk of heart failure because of this AV fistula. See, you have to understand that a patient already having an underlying heart disease, along with that the individual has developed some high output heart failure state, that will further precipitate the heart failure. Like for example, a patient with end-stage renal disease. So what will happen? There is the fluid overload that will cause the heart failure. And apart from that, these patients, they are started on the hemodialysis, for which AV fistula is being created. And AV fistula is a high output state that will further contribute to the development of heart failure. So in some group of individuals, not only the underlying disease, along with the high output states, along with an underlying disease, will further precipitate or worsen the heart failure. So this will be the pathophysiology in the development of heart failure. So if you see here, right, so we have discussed the various definitions. American Heart Association, European Society Association, what exactly is the definition? Then what do you mean by the heart failure with recovered and mildly reduced ejection fraction? And that what are the phenotypes and causes we have discussed, and the pathophysiology we have discussed. So in the pathophysiology, what is very, very important, you need to understand the concept is how is the ventricular remodeling occurring, and what are the drugs we need to target in order to prevent that ventricular remodeling. That is mainly the drugs which will inhibit the sympathetic nervous system, right? Mainly the drugs which will inhibit the RAS, mainly the drugs which will inhibit the SGLT2, mainly the drugs which will inhibit the neprilysin. That is mainly for the entire heart failure. And we have the endothelin antagonist, mainly the drugs which will inhibit the endothelin, and it will prevent the pulmonary arterial hypertension and will prevent the progression of only right ventricular failure, okay, not the entire congestive heart failure, right? So this completes the pathophysiology of the heart failure, and in the subsequent session we will be discussing the clinical features and as well as how to diagnose the patients with the heart failure, and followed by that we will be discussing the treatment of the heart failure. Thank you very much.